Hey, welcome to Book Podcaster.
Glad to be here.
So, if your brain feels like it's running on fumes today,
Hmm.
maybe you're wrestling with a mountain of notes or just trying to make sense of something that feels totally overwhelming.
Yeah, that information overload feeling. We've all been there.
Definitely. Feels like your brainwaves are just a tangled mess, right?
Absolutely. And today we're tackling a topic that can feel a bit like that. Neurocognitive disorders, NCDs for short.
Right. We've been digging into psychiatric mental health nursing, concepts of care in evidence-based practice.
We have, trying to really get under the surface of what these disorders mean, not just, the definitions, but how they impact actual people.
Exactly.
Yeah.
Because when you hear neurocognitive disorders, maybe think of like forgetting keys.
Mm-hmm.
And yeah, that can be part of it, but it's so much bigger. What we want to do in this deep dive is understand how we support people going through this.
Support them with dignity, with respect.
Yeah. Fundamental stuff, keeping them safe, acknowledging who they still are. So where do we start? What are neurocognitive disorders, fundamentally?
Okay, so think of it like this. An NCD means there's been a real shift, a noticeable drop in someone's cognitive abilities compared to how they were before.
Not just an off day, then.
No, definitely not. It's a persistent, measurable decline in those key mental skills.
Okay, key mental skills. What falls under that umbrella? Give us the rundown.
Sure. The book points to several core areas. Memory is a big one, learning new stuff, recalling old stuff.
Right.
Then there's executive function. That's like your brain's manager planning, problem solving, organizing thoughts.
So like struggling with following steps or keeping track of appointments.
Exactly. Language can be hit too, finding words, understanding speech. Attention is another one, focusing, not getting easily distracted.
Mm-hmm.
And perception, how we interpret what our senses tell us. So it's pretty comprehensive.
It really is. It touches on so many different areas. Now, the book breaks these NCDs down into categories.
Right.
It's not all the same.
Right. That's right. The main ones are delirium nugums on fast, often reversible. Then major NCD like Alzheimer's, a bigger, usually progressive decline.
Okay.
And mild NCD, sort of an earlier stage, changes are there, but maybe not disrupting daily life quite so much yet.
Gotcha. So delirium versus major NCD, that feels like a really critical difference to understand. What are the key distinctions?
They are super different, especially when you look at onset, duration, cause, and reversibility.
Okay.
Delirium usually hits suddenly, hours or days, like the brain just hits a wall.
Sudden onset. Got it.
And it's typically short-term, hours to weeks maybe, often triggered by something else, a medical issue, a substance, an infection.
Ah, so an underlying cause.
Exactly. And the really crucial thing, it's often reversible if you find and treat that cause.
Reversible. That's huge. So how's that different from major NCD?
Major NCD, what many people think of as dementia, is way more gradual, develops slowly, months or years.
Slower fuse.
Yeah, and it's chronic, progressive, caused by diseases like Alzheimer's, maybe vascular problems like small strokes, or those Lewy bodies.
And usually not reversible.
Generally, no. Treatments might help manage symptoms, slow things down a bit, but the underlying damage isn't typically fixable. That contrast, sudden delirium, gradual, major NCD is key.
Makes sense. And the symptoms people show must be different too.
Oh, absolutely. Delirium often involves fluctuating attention in and out of confusion, agitation. Hallucinations can be pretty common too.
Okay.
Major NCD is more about that steady decline in memory, disorientation, maybe language trouble, apathy, pulling back from things.
Yeah, that table in the book lays it out so clearly. Sudden versus gradual, short versus chronic. And you mentioned Mrs. Jenkins, the UPI example.
Yeah, Mrs. Jenkins is a perfect illustration of acute delirium. She was in the hospital for a UTI.
Okay.
And one evening, bam, her mental state just changed dramatically. Super confused, trying to get out of bed, thought she was somewhere else entirely.
Wow, just like that.
Just like that. Classic delirium, linked directly to the infection. But once they treated the UTI with antibiotics,
She got better.
completely cleared up in a couple of days, shows how reversible it can be if you catch the underlying problem. Really drives home why you have to look for those medical causes with sudden confusion.
That's a really powerful example. Okay, so we've got the basics, the difference between delirium and major NCD. Now let's dive into the different types of major NCDs. What are the main ones?
Right, several key types. Alzheimer's disease is the most common one.
Okay.
What's happening there is you get these amyloid plaques and neurofibrillary tangles building up in the brain, messes with brain cell function.
Plaques and tangles. Sounds kind of messy.
It is, unfortunately. Leads to that gradual decline in memory, language. Often see issues like wandering too.
Got it. What else?
Then there's vascular NCD, related to blood flow issues in the brain, often caused by a series of small strokes.
Right.
And this often leads to what they call a stepwise decline. So not smooth, but like periods of stability, then a sudden drop after a stroke event.
More like stairs than a ramp.
Exactly like stairs. Mood swings, emotional ups and downs are common too.
Okay.
Lewy body dementia. This involves these abnormal protein deposits called Lewy bodies.
Lewy bodies, okay.
Key signs are visual hallucinations, seeing things that aren't real, and motor symptoms, kind of like Parkinson's.
Parkinson-like symptoms. Interesting.
And a really crucial point, people with Lewy body dementia can be extremely sensitive to antipsychotic meds.
Oh, wow. That's vital to know for treatment, right?
Absolutely critical. Needs careful diagnosis and very cautious medication use.
Good to know. Any others?
Then there's frontotemporal NCD. This one often presents first with big changes in personality and behavioral.
Personality changes first.
Yeah. Impulsivity, losing inhibitions, maybe repetitive behaviors. Because it looks like personality shifts, it can sometimes get misdiagnosed initially.
I can see that. You might think it's a psychiatric thing, not neurological.
Precisely, which can delay getting the right support.
Makes sense.
And finally, the book mentions traumatic brain injury, TBI, as a cause, repeated head trauma, think athletes, veterans, or even a single severe injury.
Right.
The cognitive problems depend a lot on the injury itself, where in the brain, how bad it was. It's pretty sobering to think about the long-term effects.
It really is.
Yeah.
Okay, so that covers the main types. Let's zoom back in on Alzheimer's, since it's the most common. The book outlines 7 stages. That seems helpful for understanding progression.
It is. Townsend's 7 stages give a framework. Stage 1, basically no symptoms. Stage 2, subtle forgetfulness, maybe misplacing things.
Very mild early on.
Right. Stage 3, mild cognitive decline. More trouble planning, organizing, maybe recalling recent chats. These early stages can be tricky, sometimes look like normal aging.
Yeah, easy to just chalk it up to getting older.
Exactly, which can mean delays in diagnosis. Stage 4, that's more confusion. Difficulty with complex tasks like finances, planning things.
Okay, getting more notice.
Definitely. Stage 5 is moderate decline. This is where someone starts needing help with ADL's activities of daily living, like choosing clothes, maybe remembering to eat.
A significant step, needing help with daily tasks.
Huge step. Stage 6 is severe cognitive decline. Often see incontinence. Wandering becomes a bigger issue. That example of Clara, the pianist.
Yes, Clara.
Someone like her with incredible skill and identity might not recognize family anymore.
Yeah.
Needs constant care. Yeah.
That's just heartbreaking. Losing connection to loved ones, to music.
It is, and stage 7 is the very severe stage. Often loss of speech, ability to walk, even swallow, total dependence.
Such a difficult progression. Okay, so we see the stages. What about the underlying causes or risk factors? What makes someone more likely to develop these conditions?
Several things increase risk. Advanced age is number 1 for most NCDs.
Okay.
Genetics play a role. That APOE gene is linked to higher Alzheimer's risk.
Right, the genetic link.
History of head trauma, like we talked about with TBI. Cardiovascular health is huge too. Things like high blood pressure, high cholesterol, increased risk for vascular NCD especially.
Heart health linked to brain health.
Definitely. And substance use, particularly chronic heavy drinking, can damage the brain too. Understanding these helps to think about prevention and who might be more vulnerable.
And what's happening chemically
Yeah.
in the brain itself.
Yeah.
You mentioned neurotransmitters.
Yeah, complex stuff going on. In Alzheimer's, a key issue is a big drop in acetylcholine.
Acetylcholine, okay.
It's vital for memory and learning. So less acetylcholine means more cognitive problems. This is why some meds try to boost those levels.
That makes sense. It connects the biology to the treatment.
Mm-hmm.
So speaking of treatment, what about medications? What can pharma offer?
Meds can help manage symptoms, especially in Alzheimer's. Donepezil, that's Aricept, often used in mild to moderate stages, slows decline by boosting acetylcholine.
Any side effects to watch for?
Yeah, GI issues are pretty common, like nausea or diarrhea.
Okay, what else?
Memantine, or Namenda, works differently, protects brain cells from glutamate damage, usually for moderate to severe Alzheimer's.
Got it.
Rivastigmine Exelon is another one that boosts acetylcholine. It comes as a patch, which can be helpful for some folks.
A patch option, that's good. And what about those behavioral symptoms, agitation, hallucinations?
Right. Antipsychotics might be considered for severe agitation or hallucinations, but you have to be incredibly careful.
Why is that?
There's a black box warning from the FDA for use in older adults with dementia. increased risk of stroke, even death.
Wow, serious risks.
Very serious. So they're usually a last resort only if non-drug approaches fail and the symptoms are causing major distress or safety issues.
Okay.
Antidepressants, especially SSRIs, are often used for depression, which is common alongside NCDs. But overall, meds are just one part of the picture, always weighing benefits and risks.
Absolutely. Sounds like a very careful balancing act.
hmm
Okay, let's shift to the nursing side. How do healthcare pros assess someone suspected of having an NCD?
Assessment is crucial. It involves looking at a few key things. The Mini Medical State Exam, MMSE, is a common screening tool. Tracks cognitive function over time.
The MMSE. Okay.
Nurses also do careful behavior observations, watching for wandering, agitation, aggression, and that sundowning thing, confusion getting worse later in the day.
Sundowning, right?
Assessing functional ability is vital too. Can they manage eating, dressing, bathing, the ADLs? And really importantly, assessing the caregiver. Looking for signs of fatigue, burnout. Caring for someone with an NCD is incredibly demanding.
That sample nursing note in the book really brings it home. Client unable to state year, doesn't recognize spouse, tries to leave, caregiver exhausted. Paints a clear picture.
It really does. Highlights the challenges for everyone involved.
So based on those assessments, what kinds of nursing interventions really help?
It's usually a mix of things. A calm, predictable environment is key. Reduces confusion, anxiety.
Makes sense. Keep things stable.
Using orientation cues helps too. Clocks, calendars, labels on drawers helps ground them in time and place.
Simple cues.
Sticking to routines provides predictability, reduces agitation. Reminiscence activities, talking about the past, looking at photos can be really comforting, helps maintain that sense of self.
Connecting with their past.
Yeah, and when someone's confused or saying something inaccurate, it's usually better to redirect them gently than to confront them directly.
Redirect, don't argue.
Exactly. And safety is paramount, of course. Secure environments, maybe wander alarms if they're at risk of getting lost.
You mentioned that grounding example for mild NCD, saying like, today is Monday, May 7th. We're having lunch soon.
Right. Those simple, repeated reminders can be powerful anchors to reality when cognition is declining.
Such a simple thing, but potentially really effective. And obviously, supporting the family, the caregivers, is massive. What do they need to know?
Oh, family education is fundamental. They need to understand the likely disease progression, what changes to expect, how to adapt care.
Preparing them for the journey.
Absolutely. Teaching them about self-care, connecting them with support groups, that's vital to prevent burnout.
Can't pour from an empty cup.
Exactly. Early talks about advanced directives, safety planning, educating them on nonverbal communication as verbal skills decline,
Good point.
and helping them understand validation therapy. That quote from Townsend nails it. Validating their reality, even if distorted, reduces anxiety, builds trust.
Validation of the client's reality can reduce anxiety and foster trust. It's about meeting them where they are, isn't it?
Precisely. Focusing on the feeling behind the words, not just the factual accuracy, constantly correcting often just increases frustration for everyone.
Yeah, that makes total sense. Now, to pull it all together, the book had that case study of Mr. Thomas.
Yes, Mr. Thomas, 72 years old, moderate Alzheimer's.
What were the issues there?
His wife was dealing with him, frequently accusing her of stealing his wallet, though he just misplaced it. And he got very agitated in the evenings, that sundowning effect.
Okay, common challenges. What interventions helped?
They focused on a really predictable daily routine to lower his baseline anxiety.
Routine helps.
When he got agitated, his wife found that playing familiar music from his youth often calmed him down. Redirection, using something meaningful.
Using music. Nice.
They also labeled drawers and belongings clearly in his room to reduce confusion about where things were.
Environmental cues again?
And maybe the most important piece, his wife joined an Alzheimer's Association support group. Got emotional support, practical advice, community, so vital for caregivers.
That case really shows how you weave together different strategies: routine, redirection, environment, caregiver support.
It really does. It just highlights that care needs to be personalized, tailored to the person, and always supporting the family too.
So wrapping up this deep dive, it's so clear that understanding NCDs isn't just about lists of symptoms. It's about grasping the huge impact on people and families.
Absolutely. And recognizing the vital role of compassionate, evidence-based care.
The key things to hold on to, that big difference between delirium and major NCDs like Alzheimer's.
Right. Delirium often being reversible, major NCDs usually progressive.
Understanding the different types, like vascular or Lewy body, and how they present differently.
Yeah, and remembering that care has to be individualized, supporting the person and their caregivers. Those person-centered interventions make a real difference.
It's definitely a lot to take in. And if you are studying this, maybe you're a nursing student facing exams, it can feel like drinking from a fire hose, right?
Oh, for sure. It's complex material.
But just remember, breaking it down, understanding the core concept, seeing how it applies in real situations like Mrs. Jenkins or Mr. Thomas, that's how you build that solid foundation.
You're putting in the work, learning this stuff. That's what matters.
Seriously, you've totally got this. Take a breath, maybe grab a coffee or something, and just know you're building really important knowledge. Keep going.
You really are. Keep up the great work.